Good evening. My name's Jackie Hislop, Principal Clinical Researcher at Canon Medical. And for these 2 weeks, I'm delighted to welcome you all to our online MSK Day. This evening marks the beginning of 5 exciting sessions packed with incredible speakers exploring everything musculoskeletal. The first 2 days will focus on imaging in sports medicine with a special focus on the elite athlete and the imaging practicalities of return to play evaluations, followed by a session on imaging MSK pain, which then leads nicely into our session on the role of MSK in oncology. And we finish with our 5th session focusing on imaging MSK conditions that are most often associated with aging. I do hope you enjoy these days we are about to present as much as we've enjoyed bringing together all of these very talented people to present to you. So tonight we'll begin with MSK conditions in the athlete and how imaging can bring clarity to both condition and treatment plan. We have 4 informative presentations led by experts in the field. Now it gives me great pleasure to introduce our moderator for the evening, Dr. Eva Lopez. Dr. Lopez is the Chief Radiologist at Hospital de la Ribera and the European Musculo Institute in Valencia, Spain. Dr. Lopez, the session is yours.
Thank you very, very much for this kind introduction. And I would like to welcome all you from all over the world for these beautiful and really amazing 5 days of musculoskeletal joints and oncology and sports. So I would like to really welcome you to the first day, which is going to be on joints, tendons, and ligaments. And we have 3 wonderful speakers. I don't count as a wonderful one. So I hope you will enjoy the sessions, and please ask all the questions that you would like to know more about it, and we'll try our best to answer them. Our first speaker is Dr. Jérôme Renaud. He comes from Paris, and he's actually the chief of the Olympic Games. He went to Rio with the Olympic Games, and he will be the chief in Paris in the new Olympic Games. So it's a real pleasure to have you here on board, and we are looking forward for your presentation.
Thank you, Dr. Lopez. Oops. So first, I want to thank you for this invitation. I'm just removing that. So we're gonna talk about sport imaging and the impact of the technology on sport performance. So why is imaging so important? First, as you know, you had major technical improvement in the last decade, mainly for MRI and ultrasonography. Well, we have an increased weight of money in professional sport, and this enabled teams to have better medical services. But there is also some issues. First, the benefits of this high diagnostic accuracy often outstrips our ability to clinically evaluate the patients. I'm going to start with a small feedback after 3 Olympics, talking about London, Rio, and Tokyo. I am lucky to work in the French National Sport Institute called INSEP in Paris. And there we follow athletes years before the games, sometimes from their childhood. And we share everything with them, hopes, doubts, difficulties, until this very important point on their career. And our first goal is this, getting the performance. But the life doesn't stop with the Olympics. Some athletes, of course, aim for the next Olympic Games, but many of them had to come back to normal life. And we have to treat them like normal patients, and the overall goal is to help them to get a healthy life on the long term. Some data about Olympics. During this particular occasion, athletes need to be operational at all costs, and they need quick answers. So we have 2 goals. Medical teams need first to prescribe the right imaging modality for the right question, And each finding we have in this imaging will need a specific decision for the right management. If you see the intensity of the works during, for instance, Tokyo, you see that the number of daily polyclinic patient encounters were very high, up to 600 some days. If we're speaking about imaging, as you can see, we have more or near than 1,000 imaging performed on patients during each games. On this one, mainly MRI. We're going to talk now about the different imaging modalities. On the one hand, we have X-rays and CT scans, only for the bones, as you know. And on the second hand, we have MRI and ultrasonographies, which are very good for soft tissues, including joints, but it can also see bones. And if we take a look at the epidemiology of sport lesions, as you can see, bone only represent 5%. So we'll talk mainly about MRI and ultrasonography, but we have to talk a little bit about X-ray and CT scan because this is very important. You have acute lesions, acute fractures, stress fractures, and you have overuse and chronic lesion like osteoarthritis. So show you some examples like this acute fracture, very easy to see, but other example like here with a very subtle gray line here. And in this case, you have to perform a CT scan to see this gray line here, which was a stress fracture on here on the axial image. But with the X-rays, you can do another kind of exploration with weight bearing. And this is very important because you can see other lesions than only bone lesion. And here you have this tibiofibular diastasis, meaning that you have a syndesmosis lesion. And this finding is very important to manage the patient. In the chronic phase, you can have this kind of pictures here, hip osteoarthritis, and arthrogram with CT can show you this very common finding in athletes with this little bump here, which can lead to cartilage lesion, labral lesion, or even osteoarthritis. Talking now about ultrasonography, it's very important to use high frequency probes or you cannot do anything. Though MRI remains the pillar of sport imaging, ultrasonography has a higher resolution than MRI. It's, in fact, has a lower field of view and a lower contrast. And I think if you do this kind of examination, musculoskeletal ultrasonography, you have to have a very strong expertise. But to my mind, ultrasonography is really the best tool if you know exactly where to watch. Here, an example of a common tendon tear on the hamstring, on the axial view, and here on the sagittal view, where you see the disruption of the tendon fibers, the disorganization, the loss of tension. MRI now. MRI is the gold standard for everyone, athletes, team doctor, coach, everybody wants an MRI. It has a really high contrast, and this confers almost a full sensibility and reproducibility, which is very important in this case. Furthermore, we have a large field of view, and this allows to rule out differential diagnosis. Here, an example on hamstrings, where you can see you have lesion on both sides, on the right side, on the left side, and this contrast leads you directly to the lesion, and it's very easy to see. Well, it might be the ultimate imaging tool, but we have many pitfalls, and you have to know these pitfalls if you want to use correctly this MRI. First, this high sensibility is responsible for a large amount of false positive. And secondly, we have some anatomical structures composed with a very small amount of water that are not apparent. Like in this case, as you can see, I don't know if you can see, maybe like this, yeah. This Achilles tendon is totally black. This means you cannot see it. And the cortex here of the bone is black too. You cannot see it. And you have to know this if you want to understand the image. So how to use this imaging modality? First, you understood if you have a fracture, X-rays and CT scan are the best. But if you think there can be a stress fracture, MRI should be the choice. For soft tissue, you have two possibilities. If it's superficial, ultrasonography will be better. But if it's a deep structure, choose MRI. For joints, here again, we have two possibilities. In acute condition, the first 6 weeks, use MRI. But after the 6 weeks, if you still have pain, disability, you should use arthrogram with CT or MRI. But with all these informations you will get, what the point? Because for the athletes, the question is very simple, can he play? But for the radiologist, the answer is very difficult because you have many variables which have to be considered. First, what is the clinical examination? What is the timing? Do we have an Olympic final? Are we at the end of the season? What kind of sport does he do? What's his position for a team sport? How is he? What is his mental status? Does he have other injuries? Mainly, which is very important, will our choice compromise his future health? So the key point is teamwork. These two pictures are from Rio Games, and you see we have 5 actors: the athletes, the radiologist, the physiotherapist, the team doctor, and the coach. And we need these 5 actors to take the decision. The critical point in imaging in elite sports is assessing the prognosis. We are always asked to assess the return to play. The first thing to understand is we cannot wait for a complete healing of the damaged structure. It could take from 3 months to like a year for a tendon. But when you look at the literature, most athletes go back in less than 20 days. So these ascertainments are the same for imaging. If you want to control before the athletes go back, the pathologic findings are remaining. So can we rely on something else? Maybe on imaging classification. I took the example of muscle injury classification. As you know, we have many classifications, more than 30. And in this classification, they propose a prognosis for grades. I took 2, the BAMIC from United Kingdom and the INSEP, what we use in France. And as you can see, for the higher grades, prognosis is poor. But if you take the other grades, the lower grades, the prognostic is quite the same. You have a very strong overlap between the different grades. So if the athletes comes to you and ask, will it last 5, 10, 15 days, you won't be able to respond very precisely. And the problem is most of the lesions are of lower grade. So how can we do? Look at this example. Here you have an international soccer player. He had a sudden onset pain on the posterior thigh. We made an MRI, we made an ultrasonography, and you can see maybe it's easier on MRI, this white area here, this focal disorganization on the biceps longus. You see that connective tissue directly connected to the tendon is involved, which is normally correlated with a poor prognosis. So maybe you'll tell him maybe 2 or 3 weeks, but now we have the answer and it's 3 days. And he played 90 minutes. Why? Because imaging is not all. Isokinetics testing were okay. He almost had no pain at day 3. and he was a striker. And when you see him play, well, he was not moving that much. So the last thing, the most important thing, it was for the final of Olympic Games. So he had to play. I want you to remember these take-home points. First, you cannot avoid imaging in elite sport medicine. We cannot go back now. But all these information you will get are just a part of the diagnosis and merely helps for the prognosis. And remember the importance of teamwork. In France, we used to say that the medical point of view is counting just 1/3 of the final decision. But if you use the imaging modalities wisely, this will comfort you with the right diagnosis. And if you're wrong, it will correct you and give you the good diagnosis. I thank you, and I hope we will see you for Paris 2024.
Thank you very, very much for this beautiful presentation. And indeed, we would love to see you in Paris 2024. It is my time to introduce my lecture. As I was introduced, my name is Eva Llopis. I'm the moderator, and I work in Valencia in Spain. And my duty today is to talk about something, a little tips on what I call the dark sides of the knee. And the dark side, because it's where I think really that radiologists might help much more than in other. So as you see here, it's just that I'm responsible for anything. And it's important, and I divide it into chondral delaminated injuries, some meniscus tips, and some ligaments. But what I want to enhance is that it's important that you realize that you see what you look for and you recognize what you know. So, and to report an EMRI is very easy, but there are some areas that are more difficult, and then they make it not easier. And that's why I put always this sentence of Albert Einstein: things should be made as simple as possible, but cannot be make it simpler. So starting with the chondral lesions, and I'm only going to give a few tips. What's the concept of the lamination injuries? Well, the concept is a separation of the articular cartilage from the underlying subchondral bone at the tite mark, usually at the junction of the non-calcified and the calcified cartilage. It's usually associated with twisting and traumatic shearing forces. And the preoperative is essential. Why? Because of two things. First of all, if there is no fissure, so it's occult lesion, cannot be seen sometimes in arthroscopy, so they need to know where it is. And extension, it's also very important, as surgical planning can be different if they only see direct vision. I'm going to show you in some examples. So this is a nice example of a concealed or closed chondral lesions. You see the high signal intensity between the cartilage and the subchondral bone. You see it here on the beautiful MR of the coronal plane, where you see the separation between the cartilage and the subchondral bone. And sometimes, as you can see here, the problem is that this delamination, and you can see how this shear force separates, and it's like a carpet between the subchondral bone and the cartilage. And it's much more extensive than you can think when you only see in these two different examples where you can see it with arthroscopy. So if you see here how it extends, and here on this axial plane, beautiful axial plane, how it extends. So it's very useful, the information that we can show on MR. Of course, loose bodies are also important because sometimes it's not that easy to find them. And here you see an example of an athlete, and you see the chondral lesion with full thickness defect on the posterior side of the medial femoral condyle. And here you see nicely how the loose body can be found. Okay, we continue with the second topic, which is meniscus. And the first thing that we have to know is some pitfalls. So we don't name it tears where there is actually a normal structure. And we have many of them. I'm just going to show you a few examples. You can see here a little bit of the generation of the posterior horn of the medial meniscus, and it doesn't get into the articular surface, so it cannot be called like an injury. Meniscal flaws, it's a lesion that of rough appearance of the inner margin of the meniscus, more frequent at the medial meniscus, and it doesn't increase the risk of meniscal injuries. However, if you see a discoid meniscus, which is just a big meniscus that crosses and stays and doesn't lose the normal bow tie appearance of the meniscus, because it changes the biomechanics and the support of the joint, it increases the chance of a risk of meniscal tear, and they can come with the feeling of blocking of the knee. Also, you have to realize that on this, especially on the anterior horn, we can have an estuate appearance, and sometimes you can have some small ganglion cyst that we should not be mistaken with a tear of the insertion. But on MR, what we know, it's extremely useful tool. It has a positive predictive value of 90%, and I will say sometimes, depending on the magnet, can even be more. It can help to select which patients should undergo surgery, and we can say which injuries we think they are unstable. We'll go over that. But also has one important thing, which is a high predictive negative value, and that means that this patient should not go to arthroscopy, and can be clinically suspected, but negative results of an MRI is a very important thing. So the criteria for unstable tears, and that information is one of the things that I think that it's not only reporting if you have a tear or not. You have to report much more on meniscal tears. We have to say if the meniscal is displaced, because this is unstable, and that means that should go under surgery. If the lesion is big, more than 10 millimeters is usually the arthroscopy cutoff. The cleavage plane and the pattern as complex injuries of the meniscus lose the ability to protect the cartilage, and which is the problem is that the fluid goes over the meniscal tears, and these stable at the beginning lesions can become unstable, and if become unstable, the risk is to develop a flap. And I'm just going to show you a few nice examples. So although these are the classic, we're not going to review the classic meniscal tears. We're going to go to the more extraordinary small lesions that are more difficult to see, and that help really very much the surgeon to plan how they have to do the surgery. And that's our meniscal flaps that can come from an horizontal or longitudinal tear. Some special bucket-handed meniscal, the meniscal root tears, the ripped type of tear of the external meniscus, and meniscocapsular separation. These tears are also in the more difficult areas of the arthroscopy, sometimes called the blind spots. So here we see a meniscal flap, and usually they come from horizontal tears that become bigger, and then the fluid desiccates, and then they separate one floor of the meniscus from the other. You can have the meniscal flap that goes inferiorly, displacing, in this case, the medial collateral ligament, or you can go on the upper part, displacing also the medial collateral ligament in this case. But we can have funny shapes, as you can see here on the intercondylar notch and in the posterior, that looks like a cobra, a snake. The bucket handled is nowadays not difficult with the high quality MRs that we have. And you know, all of them, they come from longitudinal or vertical variant, they are unstable, and the meniscal goes into the intercondylar notch, as you can see here very nicely with the classic signs of bucket-handed. However, sometimes it's more tricky, and you can see here a nice example of a meniscal bucket-handed where there is a flip completely of the meniscus anteriorly. Or what about this case? In this case, you can see there is you can think this is a bucket-handed, but what about this? It's difficult, and I'm going to see if I can show you the video and demonstrate to you that there is a meniscal. This is the meniscus. I'm going to point it here, and you can follow it posteriorly. It goes into the intercondylar notch, but see how strange images, just because it's folded one part on the other and extruded in the posterior part of the posterior cruciate ligament. Those are much more difficult and can be mistaken with other lesions, including chondral lesions. The meniscal roots, why are they important? First of all, because this is difficult. All the posterior area of the knee is more difficult for the surgeons to approach. So it's more difficult to see, but also it's essential to do the diagnosis as early as possible, because the problem is that, as you can imagine, if you have this tear and it's complete, and here you have the famous Laprade type of classification that I'm not going to go through, but it extruded and displaces, and this leads to rapidly osteoarthrosis and sometimes some stress fractures, especially on the tibial plateau. These injuries, if they are got on time, they can be sutured and it can be big improvement for the patient's outcome. Another type of lesions that I like very much are the meniscocapsular lesions. And there are many names, but the definition that I like better is a peripheral longitudinal detachment of the posterior horn of the medial meniscus due to meniscocapsular ligament tears, no greater than 2.5 in the medial lateral length, leading to meniscocapsular or meniscotibial separation, and usually are associated with ACL tears. One of the problems is that if you see the different sensitivity, this is what I say. If you know they exist, you go and look for them, and then your sensitivity and sensibility improve very much. Remember that you improve the sensibility also by just putting the knee on a slight flexion, and that improves you very much. And you're just going to see a few examples. You remember, associated with ACL tears, there is a line of signal intensity separating the meniscus from the capsule. You can see some irregularity on the posterior horn, some fluid, and remember also this bone marrow edema, that is an important indirect sign. Okay, again, there's different classifications that we are not going to go, but you can see partial tears, complete tears. One of the important things to say, if it's more or less than 1 millimeter. Another difficult type of tears is the Risbel tears, and it's a longitudinal tear of the posterior horn of the external meniscus due to the traction of the meniscofemoral ligaments. And what you see is the separation of the meniscal horn on the axial plane, and here, or in the sagittal plane, you can follow it very much and differentiate them from the pitfall of the meniscofemoral ligaments. What about the ligaments? And I'm only going to talk just a little bit about one pitfall, which is mucoid degeneration of the ACL. And you can see some increasing now intensity, can be focal, can be cystic. And remember, when it has some bone cyst, it can be associated with pain. Another important thing of the ACL is that we know nowadays that the ACL is divided in different fascicles, especially the anterior medial and posterior lateral. And remember, what is important is the partial tears might have a different surgical approach, selective bundle reconstruction, and have some ability to heal. Remember, with ACL, it's also important to rule out other associated injuries, and the contusions can be associated with chondral lesions. What about the PCL? The PCL, what's important is to remember that this one has a little bit of ability to heal, and that's important to remember. So about the medial collateral ligament, we have different gradings, and I just want to point this special type of injuries with isolated deep fascicles, which are important because they reinforce against rotational forces. They need more time to repair, and that's very important for the outcome of the patients. I'm not going to talk about the posterior corners, just to remember that these areas are difficult to see on arthroscopy. They are difficult to see for the surgeons, and it's very important our role diagnosing them in these locations. Remember, in the posterior medial corner, that almost all the anterior medial rotational instability, they are always involved, these posterior medial structures, the pole and the posterior oblique ligament, the popliteal oblique ligament. And also, what about the posterior lateral? Well, we know they are extremely important, and again, associated with high instability of the rotational instability. Here we see an avulsion of the fibula with avulsion that includes the bicep femoral, the popliteofibular ligament, and here in this other case, we see beautiful, as we can see, an avulsion of complete avulsion of the popliteal tendon. Okay, Not going to talk about anterior lateral ligament. It's also, if it's as big as this, as Segont reported, it's very easy to see, but sometimes it's more difficult as this subtle avulsion. And again, the problem is it leads to rotational instability and might need a reinforcement on the anterior capsule. So my conclusions is that you see what you look for and you look for what you know. MRI is an exquisite tool, but needs time to recognize and get time to see all the corners and difficult areas of the knee. Some lesions might have different recovery times, and some lesions might need additional arthroscopic portals. That's why our role is very important in this kind of patients. And with this, I thank you very much for your attention, and I will be extremely happy to stop sharing my screen and introduce our new speaker, Dr. Onishi from Pittsburgh. He's going to talk about ultrasound, ultrasound guided repaired. Thank you very much, Dr. Onishi.
Thank you so much, Dr. Lopez. Thank you again for your kind invitation to MSK Day. And of course, thank you so much, Dr. Lopez, for a wonderful, kind introduction about me. I'm honored to be amongst the giants of musculoskeletal imaging today. My name is Kentaro Onishi from University of Pittsburgh Medical Center in Pennsylvania, United States, Department of Physical Medicine, Rehabilitation, and Orthopedic Surgery. And today I'll be speaking to you about ultrasound-guided anterior talofibular ligament repair. Here's my conflict of interest. None of these influence the content of my presentation today. I am involved in numerous research projects related to diagnostic musculoskeletal ultrasound, evaluation of meniscus movement, as Dr. Lopez just talked about, and the biological experiments in tendinopathy. As you can see, I received royalty from the book that I've written last year during my time at Tokyo Olympics. Today, we will first review the etiology of chronic ankle instability. Then we will discuss the biomechanical data, followed by a brief description of the ultrasound-guided ATFL repair procedure itself. Then we will discuss the early clinical data on this procedure. Let's discuss a case. A soccer player sprains her ankle. This was her third time spraining her ankle. Her pain's improving, but she continues to experience instability, and she feels that she's unable to change directions as quickly as before the injury. This is a common clinical scenario sports medicine physicians, radiologists alike face frequently. This is one of such conditions when we can consider this new procedure called ultrasound-guided ATFL repair. None of these work would have been possible without my collaborators. Dr. Soichi Hattori is an orthopedic surgeon from Kameda General Hospital in Kamogawa, Japan, who was instrumental in conceiving the idea of using ultrasound to perform ATFL repair and the execution of the clinical portion of the data collection. Dr. Rich Debsky is the director of Pittsburgh Orthopedic Robotic Laboratory, where this biomechanical experiment I will be speaking to you was conducted. Dr. Michaelis Hogan is a foot and ankle surgeon at University of Pittsburgh, who recently was named as the department chair. As most of you know, lateral ankle sprain most commonly results from a forced inversion and adduction while the foot is in plantar flexion. Ankle sprain comprises as much as 30% of all sporting injuries, and it is believed to be one of the most common sporting injuries, if not most common. Most of the ankle sprain involves injuries to lateral ligament complex, or LLC. What is LLC? Well, LLC is comprised of ATFL, CFL, and PTFL. 90% of lateral ankle sprain involves injuries to ATFL, while CFL, or calcaneal fibular ligament, is involved in about 50%. PTFL is rarely involved, accounting for just less than 10% of all ankle sprain. 20% of acute ankle sprains progress on to chronic ankle instability, or CAI, according to Dr. Takao's publication in American Journal of Sports Medicine in 2012. Dr. Takao defined the CAI as the perception of instability associated with chronic pain, avoidance of sporting activity, or recurring sprain. 10% of all ankle sprains fail conservative treatments such as physiotherapy, injections, and these cases are considered for surgical stabilization. There are two types of ankle instability. The first type is known as functional or subjective instability. And in this type, there's minimal laxity on a clinical examination. However, patients feel the ankle is unstable, such as the case presentation I just talked about. And this type of ankle instability results from poor proprioception, muscle weakness, or range of motion deficits. The second type is called mechanical instability. And in this type, the laxity is noted during a physical examination, such as the Salka sign shown in this video on the left top corner during the anterior jaw physical examination. The weight-assisted X-ray had been used, but this is associated with a high false negative rate. Ultrasound is also becoming a popular option, as you can see in this ultrasound video. A 2016 publication from Dr. Cho documented that the manual max stress versus resting ratio of 1.3 in terms of length of ATFL can be used to assist a diagnosis of ankle instability. Of course, our University of Pittsburgh team is also working on a new and improved version of sonographic dynamic assessment of lateral ankle instability. This is more as a clinical device here. In evaluating calcaneofibular ligament and its integrity, our 2019 KSSTA publication showed that the fibular side of CFL, as you can see in the middle picture, was ankle neutral, makes it very difficult for you to see the fibular end of the calcaneofibular ligament. So my advice is to keep the patient prone so that you can easily apply the dorsiflexion. And as you can see in this video, as the ankle dorsiflexes, the fibular side of calcaneofibular ligament becomes obvious and allowing you to more precise evaluation. Dr. Petron similarly described dynamic dorsiflexion to test the integrity of CFL in 2004 publication. It was a competent, intact CFL. CFL was described to elevate the peroneal tendons toward the ultrasound transducer, like this video. So this is another way to assess calcaneofibular ligament competency. So you can see that sort of peroneal tendon rises. And I'm from Japan, so whenever I see this, I think of like a sun rising, because that's what our national flag is supposed to represent. Anyways. Go back to the historic facts about surgery in this area. Arthroscopic ATFL repair is kind of the standard of care, but in 1966, the first open surgical Brostrom repair was described by Dr. Brostrom. And this is a simple direct repair of that torn ligament. Today's standard is what we call modified Brostrom, where the anchor and suture is used, and basically the torn segment of ATFL gets drilled and it's fixated to the distal fibula. And this was, still being done as an open procedure, but in the last 10 years or so, arthroscopic ATFL repair became very popular. So let's look at the arthroscopic ATFL repair. Arthroscopic ATFL repair offers some advantages compared to the open surgery, as you can imagine. A recent meta-analysis showed a short-term superior functional outcome to the arthroscopic repair compared to the open repair for obvious reasons. However, the limitation, and this is very important, is that the arthroscopic repair, Brostrom repair, is non-anatomic. I will explain what this means in the next couple slides. In 2018, Dr. Teramoto published that the distal margin of fibula visible to medial scope during the arthroscopic repair is not identical to the anatomic footprint of ATFL. In this study, the anchor was placed and evaluated for the location of the anchor placement, which ended up being about 8 millimeter more proximal on average to the anatomic footprint of ATFL on the fibula. And this is very important findings because a subsequent study published in American Journal of Sports Medicine in 2019 showed that the 8 millimeter proximal deviation of the anchor placement resulted in internal rotation laxity. which is really exactly what the surgery is supposed to control. So it doesn't do the job it's supposed to do. We first conducted a study to see if ultrasound-guided anchor placement was accurate, and our KSSDA publication showed that ultrasound-guided anchor placement is as anatomic as open anchor placement. Here's the CT reconstruction of rendering of the ultrasound-guided anchor placement on the top, and the bottom is that of the open anchor placement. We also felt ultrasound-guided ATFL repair had a benefit over arthroscopic repair of having the capability of visualizing peroneal tendons. Due to inability to visualize peroneal tendons, an inadvertent suturing of the peroneal tendons is a dreaded complication of arthroscopic repair. The scope positioned intra-articularly does not allow an intra-operative visualization of peroneal tendons, as you can see on the right side of that arthroscopic images. However, with the ultrasound, you can see where the tendon is located, and this allows us to take an aggressive suture bite if additional tissue is needed to stabilize very lax ankle, while avoiding the dreaded complication of suturing the peroneal tendons. Dr. Hattori and our PET robotic lab team conducted a study using our 6 degree of freedom robotic machine, which is shown here. And this would allow us to load the ankle joint on a cadaver with known amount of forces and torques. And this paper has finally been published in Orthopedic Journal of Sports Medicine 2 months ago. So I'll spare the details of biomechanical data, but this basically a study showed that ultrasound-guided ATF repair resulted in normal ankle kinematics comparable to prior to inducing an injury, resurrecting normal ankle biomechanics. I will spare you the details of the biomechanical data, as obviously this was published, and also the procedure itself too, because this is now available as an open access journal. However, this is in general, the procedure is done by first performing the 2 suture repair using a Mason-Allen suture configuration repair to the ATFL that is torn. And then anchor will be driven to the obscure tubercle of the distal fibula. Then the additional good augmentation, which is a well-known augmentation performed in conjunction with primary repair, is performed to augment the repair using inferior extensor retinaculum, as shown in the middle picture. Based on this biomechanical data, our team started to perform this procedure in vivo in human subjects, and I am excited to discuss our early clinical experiences. We selected 12 subjects with chronic ankle instability who had undergone ultrasound-guided ATFL repair. We excluded patients with intra-articular injuries and peroneal tendon involvement. We used the same return to activity protocol as the arthroscopic repair in order to be conservative as we build the clinical evidences and try to be, increase the safety profile. The subjects are allowed to jog essentially by 8 weeks post ultrasound guided repair. We documented complication rate, functional scores, and ultimate return to sporting activities as our outcomes. Complication, as defined as pain level 2 or higher, or neurovascular injury, was 0 at 6 months follow-up. Functional score improved significantly. And of 6 athletes out of 12 subjects included in this initial case series, all 6 was able to return to sport and full practice by 6 months. Let's compare our data, albeit the small data, to open and arthroscopic repair. When comparing the previously published open and arthroscopic repair data, the complication rates with ultrasound-guided repair is much lower, as open and arthroscopic repair resulted in about 10% complication rate. As far as the functional score goes, 6 months score for ultrasound-guided repair group was identical to 12+ months functional outcome for open surgical procedure as well as arthroscopic surgery. So this is probably the most important figure that you can take home with. So based on our early clinical experiences and biomechanical data, we can say that the ultrasound-guided ATFL repair is as anatomic as the open repair and biomechanically sound. Further, ultrasound-guided ATFL repair may be safer than conventional repairs and may result in a quicker return to sporting activities as well as daily activities. Obviously, the next step will be a larger clinical trial before making any comments about its efficacy. Thank you so much for your attention. Here is my contact at the right bottom corner.
Thank you very much, Dr. Orsini. It has been amazing work. I'm really, really impressed. I think we all want to do this ultrasound-guided ATFL reparation, because indeed it's a difficult topic, and we'll talk later in the question and answer. So it is my pleasure now to introduce Dr. Kubel from Austria, and he's going to talk about the approach of cross-sectional imaging on a racetrack. Please, Dr. Kubel.
Good evening, and thank you for the invitation, and thank you for the kind introduction. So tonight I will talk for a few minutes about the special approach of cross-sectional imaging on a racetrack. Especially we work on the Red Bull Ring, placed in Styria, Austria, pretty close to the hospital I work. And I would like to give you a short overview about the contents. That means we will talk about the concept of medical care on a racetrack, why we provide a CT scanner on site directly on the racetrack, the situation there, problems and solutions, and a short conclusion. So the situation there is we have a chief medical officer who is placed right in race control. That means he has all the situations on video. He can see everything all the time. During Formula One, for example, he can also see vital signs of the drivers like pulse and SpO2. So there is a high level of information, and this is given to the medical center in case of an incident. So the medical center is the place where medical treatment happens most of the time. Then we have different medical cars placed on the racetrack. We have extrication teams, of course, a helicopter, and different intensive care and normal ambulance cars. As you see, the Red Bull Ring is a racetrack, of course. The medical center is placed here at the start and finish line. And all the patients, wherever they have an accident on the racetrack, will be treated as fast as possible, and then will be transported to the medical center for further treatment and decision for next actions. So in the medical center, we are equipped with an emergency room with 2 aisles for critically injured patients. That means polytraumatized patients. We can work on 2 patients at the same time. This is especially important, for example, during sidecar racing. When a simple accident happens, we have at least 2 patients to treat. We have further emergency rooms for minor injuries. We have, of course, bedside ultrasound, and in special occasions like during MotoGP, we use a CT scanner right on track. Additionally, we have 1 helicopter on site in the medical center and an additional extra helicopter in reserve on a helipad nearby. If there are more patients and we need to transport several patients on fast pace, we can use both helicopters. Additionally, we have intensive care ambulance cars to transport groundbound. In the medical center, we have a team leader who takes the decisions, but also deals with the situation around. If you can imagine, if somebody pretty famous has an accident, there is a lot of pressure. There are many people who come to the medical center and want information, and team leader needs to organize everything. We have 2 anesthetists and 2 trauma surgeons who do the main treatment, and one radiologist who tries to help wherever is possible with ultrasound and CT scans. And additionally, we have nurses and paramedics. So racetrack staff is a lot of people there. There are a huge amount of physicians, emergency physicians on track, and in medical cars, Omega cars, and in extrication teams. The decision why we try to provide a CT scanner on the racetrack is there are rules of regulations, especially by FIM, that's the organization that does MotoGP. They always wanted X-ray on the racetrack, of course, because we have a huge amount of bone injuries. And we saw an advantage in CT scanning on site to do a quick triage for transportation. So to see, is it possible to do the transportation to the trauma center ground bound, or do we need the helicopter? Because as you can imagine, if we use both helicopters, then there is no helicopter left during the race, and then it might be necessary to stop the race. We can also recognize occult injuries and, of course, critical injuries. And also a special job for the chief medical officer is that he has to decide if somebody is fit to race or unfit to race. So during qualifying, for example, if a rider has an accident, there needs to be a decision needs to be done if he's allowed to drive in the race the next day. So if he's fit to race or unfit to race. And one small thing is most of these patients are pretty famous, and it might be some kind of problem if they have to visit a local hospital for minor injuries. So for that, it's pretty practical to have a CT scan and ultrasound there. So just to describe the situation, if an accident happens, we have patients starting with 12 years old in junior cups up to 43 years old if somebody recognizes Mr. Rossi, for example. The fast accident response means we have codes. Code 0, the patient is fine, he can walk away himself. Up to code 3, he's lying on the ground, doesn't move, needs immediate special emergency care. As fast as possible, the patient is extricated from the situation. This might be a problem, for example, in Formula cars, where when they had a heavy accident, it might be not so easy to get the patient out of the car and bring them to the medical center. In the medical center, treatment starts in the higher level. We try to be as fast as possible, so we work focused but fast to decide if somebody has to be taken to a trauma center, into an operation theater, or if he can be treated in a local hospital, or maybe doesn't need any further treatment. We provide bedside ultrasound directly in the emergency room, optional CT scan if necessary. So this is a picture of the CT scanner we used this year for MotoGP. I would like to show you a short video to see the situation that we have on track. So this is a special situation for a radiologist. This is the CT scanner, and we are right at the start and finish line in front of hundreds of people. And as you can hear, or will hear, there's a lot of noise. And that's pretty uncommon for a radiologist normally. Okay, so what is my situation? We do eFast ultrasound. I think every radiologist knows what to do and what we can see and cannot see. And if the indication is there, we also provide trauma CT. Normally, we focus on the special areas we want to check, so we don't do whole body CTs, but we know what happened exactly. We saw videos of what happened right on track, so we can do focused trauma CTs. Additionally to that, we can offer MSK scans to see if smaller injuries happen, like fingers are broken or not. This might have an impact on the ability to drive, especially for motorcycle riders. And also additionally, we provide MSK sonography for additional injuries like ligaments, especially shoulder, for example. So what is the problem that we had? For example, this is the CT scanner we had 3 years ago during the pandemic. They had to provide a special solution in containers with 2 different air conditioners. Another problem is there are no really good guidelines because there is not much knowledge. As I know, we are the only racetrack in the world that uses a CT scanner on the track. So there are no good numbers if it works good, if it works bad, if we see bleedings, like patients come to us 3 minutes after accident, and if we do a CT scan of the brain, you might not see a bleeding, of course, because it's not visible yet. There is a lot of pressure because time is gold in our situation. Also, there is a lot of pressure because many people want to get a report as fast as possible, if possible, in between seconds. And there is some pressure because people are famous. We have time management and space problems. This is a picture of the CT scanner we had this year. So this is the CityHopper solution Canon provides, and that offers a bit more space and a bit better situation for us, because if you imagine there are a lot of physicians and paramedics who work on the patient, so space is limited. We have noise on the workstation, and especially at the timing of the examination, and also the indication may be difficult because offering a CT scan may delay the transport to hospital, and especially with high-level bleedings, a CT scan on site can be a disadvantage for the patient. So it has to be checked in every case if it makes sense or not. The advantage is we are fast. We can detect occult and severe injuries. We can exclude fractures for fit to race decisions, and we can sometimes maybe prevent race interruption. The conclusion altogether is it's an individual decision to bring CT scanners into play on the racetrack, and it's a constant learning process. We have now 3 years of experience, and it's growing, and we learn with every bigger race. We learn more about the situation and how to use imaging the right way and the fastest and most positive way. And last but not least, maybe in the future, cross-sectional imaging on a racetrack might be or might have the potential for further invasive trauma treatment. Thank you very much for the invitation, and have a nice evening.
Thank you very, very much also for this wonderful presentation showing how well organized you have it. It's actually very amazing that how could you really have all these equipment next to the race. It's really, really nice. So I think I am going to ask the panelists if you can put your videos on, and we're going to start trying to answer some of the questions. I would like, because we with all the presentations, I think with more like a logistic type of presentations, how can you organize and how helpful can be to be next to the patients, and more specific ones as the beautiful how to help with ATFC, and especially with this very difficult topic, which is the treatment of anterior lateral instability of the ankle. How can we be very focused? So we saw beautiful different types of presentations, but all of them highlight how important is imaging for the outcome, for the prognosis, for making decisions, and how radiologists can be very, very close to the patients and can be part of the team, as Dr. Jérôme highlight to us. So I would like to start asking one question to Dr. Jérôme Renaud, which is how logistics do you organize to the Olympic Games? So do you have tracks? Because of course, some of the tournaments are not always on the same place. Do you move these tracks? Do you have, as we saw in the racetrack, tracks that are fixed there with cities of MR suites, or how do you think is the best organization with your experience?
For an event like Olympic Games, we concentrate all the imaging facilities in the Olympic Village. We make a polyclinic here with, well, it's not trucks, but big containers. We need special trucks to bring them here, and we cannot move them. For the other side of competitions, we have a special arrangement with local hospital, local facilities, because as you know, we will have sites in France, in other cities, well, even in Tahiti, in the Pacific Ocean. So very difficult to move our truck from Paris to there. So, well, this specific organization will be held in Paris, in the Olympic Village. And for the other one, we'll deal with the local organization.
Okay, thank you very, very much. I think logistically, it's difficult. Thank goodness we have now PACS systems that we allowed you to, despite the imaging moves and can be far, that you can really go and report it from distance. And so I always thought that one of the biggest problems is that ultrasound can be really moved really close to where the game is, and sometimes even the problem is that we do the imaging so fast that we can even make mistakes. What do you think about that?
Yeah, you're totally right. It's a big problem because the fact we can easily bring ultrasound just next to the athlete field lead us to do too quickly these examination. I had issues like in international tennis game in Roland Garros, where they asked me to do a ultrasonography of an ankle 30 minutes after. And well, if you don't wait, you won't see anything. The problem with the ultrasonography is you need to see the edema. You need to see the blood, and it takes time. So usually we ask approximately 12-24 hours to have a good sight, a good idea of what happens. But well, we make this on the 31st minutes. We tell them we don't see many things, or we tell them we see these things, but we have to do this again 24 hours later. It's very important that they understand it.
Okay, thank you very much. I have more or less the same experience. And so there is a question, and I can think all the panelists can also give us their experience. Do you need a therapeutic ultrasound is different from diagnosis ultrasound? I suppose they are talking about the machines, which in my opinion, they are not. And usually it's the same. You can perform ultrasound diagnosis with the same machine that you're supposed to do therapeutic. Is there any different answers that you can help Fayyab bin Aftaf? So do you need a special ultrasound machine to perform interventional radiology? I would say no.
Same response for me.
I agree. Perhaps maybe this is a question from physiotherapists, and they're talking about therapeutic deep heat ultrasound versus maybe perhaps like diagnostic ultrasound. I'm actually not sure the context of the question. However,
yeah, no, neither do we.
However, I agree with you. If we're talking about interventionally used ultrasound for guided procedure versus diagnostic ultrasound modalities, it's the same machine can be used, with strong preference to use higher frequency transducer, as Dr. Jerome stated earlier, for small, however painful condition it is. So I think a sticking needle is easier. Procedure is a little easier. It requires maybe less frequency. For diagnostics, it would be nice to have a high frequency transducer.
The better, the best, more or less. Okay, there's a lot of questions about the ankle stability. So I'm going to try to organize them. So first from the opinion, and I think also this is open for the discussion, is that which would be your preference on diagnosing ankle sprains, ultrasound or MR? I will give my opinion, the last one.
MRI would give you information on intra-articular involvement, which is an important, not to be missed component in evaluating, especially athletic injuries. So I would prefer to have an MRI. However, on the sidelines, as we earlier alluded during the Tokyo Olympics, so I actually led the IOC venue ultrasound program during Tokyo 2020, with IOC research team, and brought ultrasound to 7 competing venues and used the ultrasound to diagnose 14 acute musculoskeletal and non-musculoskeletal injuries. And non-musculoskeletal injuries include lung contusions and dehydration using IBC, ratio, collapse ratio. And then 12 musculoskeletal injuries included a grade 2 sprain sustained by one of the Team USA volleyball players. And it's useful. And when you start seeing the anechoic regions within the anterior lateral ankle space, you begin to think perhaps this ankle might have intra-articular involvement. So obviously you need an MRI to confirm that intra-articular part. So my answer would be to use MRI as a requirement, ultrasound assistive on the sidelines.
What about Dr. Kubel?
I have no special things to say about that because that's not my my special field I work in.
Okay, so Dr. Renaud?
If you're talking about management and with the idea of possible surgery, I think I will agree with this previous speaker. I think MRI should be the choice because, well, the intra-articular lesions are very important to diagnose, and I want to spot a special interest on the syndesmosis. And well, it's very easy to see the anterior ligament, but it's very easy to miss a lesion from the interosseous membrane, and interosseous ligament. So, and this is very important for the management. So maybe if you're talking about surgery, about this kind of management, maybe MRI is my preferred modality.
Yeah, I think for all what you said, and I agree completely. First intra-articular, then some are complex, deep structures that are difficult to be seen on ultrasound. And we see some periostal detachments that are that they continue with the medial collateral ligament complex, and I think that gives you, of course, in the much more information. Sometimes the MRI. Also, if you do a little bit of bigger field of view, you don't miss mid dorsal sprain, which are also very important. Okay, so we have agreement with that. There is a lot of questions about who are doing the procedure of the ATL feet, of the F, excuse me. If it's radiologists, if it's orthopedic surgeons, please let us light on that topic.
Sure. So right now it's being performed by the person who invented this procedure, Soichi Hattori, who is a foot and ankle surgeon, who is also an expert in musculoskeletal ultrasound from Japan. And I believe, one of the things we have to consider in doing something innovative like this is obviously a safety of a patient. And, I think the dreaded, situation that we all have to be able to manage, it would be when something goes wrong during the procedure. and whoever can manage that, intraoperative complication will be the best person to be performing at this second until we accumulate complication patterns and experiences. So while I was involved in the conception of these ideas and biomechanical researches, as a physical medicine, rehabilitation, sports medicine expert, I haven't done it myself, but I think that we just have to watch and observe carefully. And then these things, while innovative, innovation requires patience and good science before we are able to do things. So right now, orthopedic surgeon is performing this for the reasons I've already mentioned.
Okay, thank you very much. There was also another question about ATLFL. If it's always associated with calcaneofibular ligaments, so always associated with ATFL.
Question is something about CFL?
Yeah, about if the most common injury of course, it is anterior talofibular ligament, like that. I don't make mistakes with the with the names. And does the calcaneofibular ligament always tear with it? I could answer that of course not. Sometimes, of course, sometimes you have isolated anterior talofibular ligament injuries, but it is true that when you have calcaneofibular ligament injuries, usually the anterior talofibular ligament is also involved. Do you agree with that?
100%, I agree with that, Dr. Lopez. And another thing that I've been witnessing since I've started evaluating this area a little bit more focused after this research project and all in the clinical practice, what's possibly a determining factor is the injury or competency, or what we call connecting fibers. The fibers connecting the ATFL and the CFL, that little slip of the tissue that we sometimes see, and we don't know how to call it because it's not technically a TFL, but it's not CFL. That I think is the break-off point. If you have that injured, the ankle most likely clinically is unstable. Has been my experience. I don't know about the rest of the panel.
Yeah, I agree completely, because I'm, as you know, this was described first by the inheritance of Paul Golano in Barcelona, and Dr. Vega has these beautiful studies on ankle instability and the two anterior talofibular ligament separations, the intra-articular and the extra-articular, and depending on which one, and these artiform fibers that connect with the calcaneofibular ligament are what we are going to probably see what is the key. And now actually with this beautiful image quality, we are trying to see if with imaging we are able to distinguish clearly. We know the arteries between the two fascicles, but we want to know these artiform fibers. And I agree completely that the key for instability probably is related to this. I agree 100%. Okay, I have a question for Dr. Kubel, and it's what are the guidelines, indications for an emergency department physician to request an ultrasound for an ankle? No, I'm sorry, this was not for you. It was more about the organization of how to, if you have some guidelines related to when are you performing different type of techniques.
The problem is
on the setting, on the setting of these acute injuries, of course.
Okay. So this is like a team decision. You have the chief medical officer who evaluates the situation, who knows everything about the impact, for example. We have the traumatologist who is in the medical center, and me too. And we shortly discuss which technique is now indicated and the best. So a basis for hard discussions is most of the time when we have young patients, like 12-year-olds who go on the racetrack, they race there and they have an incident and they come to the medical center unconscious, for example, or they have been unconscious for a short period of time. So then the decision, do we perform CT scan on site or not, is always a difficult decision, because it means radiation, it means maybe we don't see the bleeding because it's too early. And in fact, we have to say there is no real consequence out of this procedure, because if a 12-year-old or 14-year-old has been unconscious, he will be evaluated in hospital anyways and will be checked for at least 24 hours. So maybe it doesn't make sense to do a CT scan on site at these young patients. But for example, if we have a Friday session, so free training the day before qualifying, and we have an incident with special problems of the finger, then performing the CT scan might be an impact for the rider for the whole weekend. If he's fit to race, if he can perform the second training session, because CT scan takes, together with the report, takes like 15 minutes. And if he's fit to race, he can jump on his bike again and do the session.
We are looking forward to your guidelines to see if you can help us, the ones that we don't have those amazing structures. Well, there is a lot of questions on muscles. There is a question about meniscal tears with ultrasound, and if it should be done with MRI. Me, that I did I'm going to answer as I did the knee lecture. Well, the problem is that I don't think it's enough to say there is a tear. I think we need to give more information. We need to say, where is the tear, if the tear is unstable and not unstable. So I don't think ultrasound nowadays can give so much information that of MRI. And of course, it has a big problem with associated intra-articular lesions. So I'm afraid, unless it's not indicated the MRI or the ultrasound, if there is a question mark on a real problem with the meniscus, you need MRI. Perhaps Jerome, any comment on that?
No, I totally agree with you.
Yeah, I think ultrasound is a wonderful tool, but it should be used for the things that should be used. Okay, the rest are.
No, it's okay.
Yeah, so the rest are about muscle injuries, and as you remember, tomorrow we have a full muscle injuries session. But I think they're so interesting that we can just pop up for the last two questions. So, a big question: how do you manage the tendency of MRI versus ultrasound to overestimate the extent of the muscle lesion, especially low-grade injuries? And if you used diffusion. There was also a question mark about ultrasound elastography for these muscle injuries, and this is for Dr. Renaud.
We use indifferently ultrasonography or MRI. The problem is we cannot use MRI for everyone. It's a quite expensive modality. If I had the choice, the best organization will be to do MRI for everybody. And as soon as you see something bright, you do the ultrasound here, because, well, you have a very strong sensibility with MRI. But if you want to really see the architectural distortions, it's far more better with the ultrasonography. So with professional soccer player, we do this, but I'm not sure my country will be happy if I say this in front of all my colleagues. Well, for the other question, for functional MRI, we have current studies with diffusion. Well, interesting, but not revolutionary. And for elastography, it's good for the healing, but, well, for the diagnosis, we didn't find that it was very helping.
This was a wonderful approach, because usually the tendency is to do an ultrasound, and if you have some doubts, go to the MRI. So this is a really different vision of the injuries, and I saw this beautiful loss of tension of the case that you showed on ultrasound. That was beautiful, and I think that's sometimes it's much better depicted. I agree with ultrasound, but it has to be focused, because if not, you are lost in all the leg, and it's kind of difficult to find it. So I have the last question for Dr. Kubel. Do you use CT normal, or do you modify the parameters because of the radiation on kilowatts and milliamperes?
Of course, it depends on age and the situation. And for example, this year we checked that imaging of the lower spine, for example, has like the half of the radiation of a conventional plain film of the lower spine. So the fact to have a CT scanner on the track lowers the radiation numbers, like to say. And of course, also, if we treat younger patients or examine younger patients, of course, we try to lower the dose as much as possible to keep the orbiter out of sight and to do as little as possible. But in fact, of course, the best is not to do a CT scan if it's not indicated. So it's a hard question all the time.
It's always a so thank you very, very much for your attention. Unfortunately, we're running out of time and this debate has been so amazing and I would love to continue, but I think they're going to kick me because I have this tendency to talk and talk. So really thank you. It has been a very successful, we learn a lot during this 1.5 hour, and I hope to see you all in new meetings now face to face also, not only online.
I'd like to again thank our speakers and moderator, Dr. Renou, Dr. Onishi, Dr. Kerbel, and of course the wonderful Dr. Lopez for launching our MSK Days series. I think you'll agree that the presentations and Q&A session have been well worth the time spent with us tonight. And we hope that you can do the same tomorrow, where we'll explore a slightly different focus in sports medicine, muscular and critical injuries. We hope to see you again tomorrow at the same time as we trek further down the path of imaging in sports medicine. Thank you all.